I feel a little bit torn about this because I know I'm biased. I happen to be at an incredibly strong academic center that has resources. So we are able to test our patients with MDS with a molecular profile. We do a next generation sequencing based mutation platform that covers 88 genes. And so we're able to mutationally describe our patients at the time of diagnosis. What we have discovered based on some really phenomenal work from Coleman Lindsley, he published this in New England Journal of Medicine about 3 years ago, that there are mutations that are present at the time of transplantation that select for poor prognosis and short survival despite transplantation. And even increasing the intensity of conditioning cannot overcome some of these mutations, suggesting to us that we better come up with a better way to treat these patients with or without transplant or improve our transplantation strategies. So one population in particular that really suffers from poor outcome and challenges includes the P53 mutated population. When that mutation is present at the time of transplantation, their survival is short. The post-transplant survival is about 20%. If you give them a myeloablative or high-intensity treatment, they cannot overcome the poor risk features. So it's the same as if you give them a less intensive or reduced intensity conditioning strategy. Alternatively, with mutations like RAS pathway mutations, his work was able to demonstrate that by increasing intensity, maybe giving patients a more myeloablative approach if they could get it, if they're eligible, that could overcome the poor prognosis of that particular mutation. So we're really learning that different mutations require different things. And some mutations are just troublesome. So we really need to think of ways to mitigate clonal expansion and relapse post-transplant. Some work that also came about from the WashU group that was also published in New England Journal of Medicine 2 years ago was that the persistence of mutations at day 30 post-transplant is really clinically meaningful and associated with a high risk of relapse. So I really do think mutations are important. It's helping us to think about who should go to transplant, who shouldn't, or who should go to transplant and when possible on a clinical trial to improve their survival and reduce their relapse risk. Because there are some patients that we just don't have a better therapy for as of today. I really hope that these phase 3 trials, at least a few of them pan out to offer them better therapies in case transplant cannot happen. And for those that do go to transplant, we have a lot of pressure on us to improve our transplantation strategies so that way their survival is better.